Over to Dr. Nitin, and he's going to talk to us on Phako in small pupils.
At the outset, I would like to thank the scientific committee for having this course. It's nice to see here all of you all post lunch. So my topic would be how to manage small pupils. So we all know that a good pupillary dilatation is something which is very important for a phacoemulsification. However, there are times when we are not able to achieve this. आगे नहीं जा रहा है. Okay, so there are various methods by which we can, there's a very busy slide, by which we can achieve intraoperative pupillary dilatation. Some are mechanical, some are non-mechanical. The non-mechanical would include a viscodilatation, a dilatation with intracameral mydriatic agents, a stretching the pupil, that is a stretch pupilloplasty, sphincterotomies. The mechanical ones would be iris hooks, rings, Malugan ring, Behex ring, and Gaither ring. So let's individually deal. Now this was a case of a Phako in a pace. Important to know how to manage when the pupil comes down during surgery, because that may be a time when it is difficult to introduce rings. So this is a small pupil case being done without any hooks or rings. So most important thing here is to make the rhexis margin as close to the pupillary border as possible, and do all your chops, a vertical chop, and definitely not a tangential or a horizontal chop, because you wouldn't know where the rhexis is. Like in cricket, it is said every batsman should know where his off stump is. It's very important to know all through the surgery where your rhexis margin is, so that you don't go beyond the rhexis margin, especially in these cases. There are chances of some amount of the fragments coming up into the chamber, so you may not be able to do the whole thing in the back. So therefore, constant refilling the chamber with a viscoelastic is very important. So the next video which I would like to show is a Phako in a patient with a small pupil, where we use intracameral mydriatics. Now, intracameral mydriatics could be either epinephrine if the patient is fit for it, so your anesthetist has to certify the patient doesn't have a cardiac problem, or you can use the Phenocaine Plus. I don't have any financial interest. There is the Tropicacil Ultra, which is basically a combination of phenylephrine with Tropicacil and proparacaine. So you see, you can achieve a good dilatation by intracameral mydriatics, and then the whole procedure is as smooth as anything else. The Varion capsular rhexis guide is for a 5.5 millimeters. So you've seen that our pupil has gone up to 5.5 millimeters, a little beyond 5.5, and therefore it's easy to complete this case. The remaining steps are quite similar to any other routine phacoemulsification, but one should know that this is something which you should use initially to see if you can achieve pupillary dilatation, and if it is possible, then you don't need to have the rings and the hooks put in, and make the case more simple. Now this is a case where we are doing only a viscodilatation because mydriatics have not worked, intracameral mydriatics have not worked. Now when we do a viscodilatation, it's very important not to fill the whole chamber with the viscoelastic. Moment you fill the whole chamber and press the iris down, you will not get a good dilatation. So you initially start off by injecting a little bit of viscoelastic, so you create a plane, and now you go to the sphincter edge and very gently, all 360 degrees, start injecting the viscoelastic in a circumferential manner, and you can see there how easily the pupil dilates. And you can believe me, there are cases here where we can do with a viscodilatation, get a pupil of at least a 5 to 5.5 millimeters. And if it is not a hard cataract, one can go ahead with phaco surgery without again the use of hooks or rings, therefore making the surgery more simpler and spending lesser time on the procedure. Now this is a case where we do a stretch pupilloplasty. So again here, after having injected viscoelastic, what we do is we use two Y hooks, one from each of the side ports, and we are stretching the pupil in the opposite direction. Now these stretches usually should be obviously in the opposite directions, and usually they don't cause a big amount of sphincter tear. There are small sphincter tears which you can notice at the end of the surgery, but you still achieve a good circular pupil at the end of the surgery in spite of doing a small amount of sphincterectomy with the stretching. Again, now having injected viscoelastic after the stretching, one can go ahead with a good pupillary size. Iris hooks are something which can come to your uh, as a savior in cases where you cannot achieve a pupillary dilatation with any other procedures. I normally prefer to use 5 iris hooks, one below, just close to the incision side, below the incision side, above the incision side. And once you get a large pupil like this, which with 5 hooks, it would be more of an hexagonal pupil, one can go ahead and do a routine Phako surgery in these cases. Again, while inserting the iris hook, your incision needs to be at the limbus and not at the cornea, because if your incision for the iris hooks is at the cornea, you will tend to pull the whole cornea up when you tighten the hooks. So following the surgery, the iris hooks can be removed. They can be either removed from the main incision or they can be removed from the incision in which it was made. Malyugin ring is another device which is available, and this works very well. So again, in these rigid pupils, we see that a Malyugin ring which comes with the injector system, we inject a viscoelastic in the chamber. This comes with the injector system where you withdraw the whole Malyugin ring into the injector, and this can go in through an incision as small as the 2.4 incision. Now, a bimanual technique is very important. You need the other hand, other instrument to be in the chamber to guide the Malyugin ring. This is like basically like a safety pin. The scrolls are like a safety pin. So the leading scroll, you try and first achieve a catch of the sphincter. The side scrolls can then be placed in the right position. One needs to create space between the lens and the iris here with the viscoelastic. Don't fully fill the chamber with the visco. Now, the advantage of the Malyugin ring here is that you can adjust the Malyugin ring in order to centralize the pupil. So as you can see in this case, we have started the rhexis. And somewhere in the middle of the rhexis, when you feel that your rhexis is going, the pupil has gone off center, and if you're centering the rhexis on the pupil, you can use a hook to try and re-centralize the pupil by adjusting the position of the Malyugin ring. The remaining procedure in this case also remains the same. A Grida pupillary expander is another device which is basically nothing but a silicon tire, which is a very elegant way. It's a silicon tire which goes in through a 2.2 millimeter incision. It's a circular tire, so here you get a nice and circular pupil. You just need a second instrument to hook the pupillary margin within the tire, and now you got a nice circular pupil. I'll just take a minute more. And following phacoemulsification, removal of this is very simple. So you just disengage the tire and pull it out with the forceps. Again, no sphincteric tears because you're not stretching the sphincter at all here. And the last case here is a device which we all are aware of, our own Dr. Suven Bhattacharji's BHEX ring. This is a very slim device. There is a learning curve, especially while using the BHEX ring, because we need to engage alternate scrolls, and we get a nice 5 to 5.5 millimeters hexagonal pupil. Again, in cases of a very rigid pupil, it may not be possible to use this ring, and iris hooks would be the savior in those cases. So there, as you can see, you got a nice hexagonal pupil. And removal of these rings following surgery is very simple. You just need to disengage the scrolls, and this can be pulled out through a 2.2 millimeter incision. The latest ring can be even inserted